So hello everybody, I'm Paulo Artal, and I'm really very happy to be with all of you in this webinar on the clinical results of our art IOLs lenses. And I really would like to thank our invited speaker today, Dr. Secundo Rechichi and Daya. And I'm really very, very happy to have them because, they choose to implant our lenses, and they were so kind to share their experience with all of you. So I'm sure this is going to be a very exciting hour of webinar. And Don, the structure is just, I'm going to give you a very, very quick introduction about the concept of the lenses, and then we will move with the speakers, and we will have questions that they will be very, you can serve. Okay.
Yes.
So, just going very quickly to the concept and why we believe that we have the best optical design in the world, and we wanted to put together two features in the lenses: one improving peripheral optics, and the other to have a good optics at all distances. So next slide. Then next. So, it's okay. So one of the initial issues we have in mind, and is very simple, and you can all understand, is that intraocular lenses are very successful, right? But optically, they are very, very different from the natural crystalline lens. The difference is the thickness. And while intraocular lenses work optically very well on apses, we, and probably others, know that they are not doing very well in the periphery. So standard biconvex lenses are really doing a very poor job optically in the periphery. Next. If you have a worse peripheral optics, this can be really a problem for daily life activities: more falls, poor object recognition, driving difficulties. So we were aware of that, and we came up with a solution. Next. A solution is just to modify the standard shape of the lenses from a biconvex to an inverted meniscus. Everything else is the same. They are very standard lenses, but we initially did a kind of theory on this, and you can see here that in the periphery, the human eye and lenses patient implanted with the meniscus lens, they have a similar image, while standard lenses, they are really much worse. Next. This is an example, right? This is with real lenses in an optical bench, and standard and our lenses, we are providing a better image quality. Next. And we proved that in the clinic. So we measure peripheral defocus and peripheral astigmatism, and was clear that patients with our lenses implanted, they were doing much better. The good thing next is that we also get a better contrast sensitivity in the periphery. Better optics, better contrast sensitivity. I know that the next question was, well, what's happened in real life, right? Next, in real life, what may happen next is that we can have an impact in a daily activity, like going downstairs, for instance. This is a realistic simulation with a standard lens and with our IOLs. Next, we also perform a very nice study, just published a few weeks ago, using a very realistic driving simulator. And the patients implanted with our lenses, they did better, especially when they were using peripheral vision, like the navigator and so on. So this is important, right? Like an extra bonus, by the way, and I have to confess that initially we were not thinking about this, our lenses are also minimizing negative dysphotopsias. I know that this is important for some doctors, not very important for others, but this is like an extra extra bonus. And of course, we will have also in mind the holy grail of today's intraocular lenses. It's possible to have near vision without photic phenomena. And our solution next was basically having a lens that has extra sphericity on top of the inverted meniscus. And next, we have three lenses, as you know. One is basically a monofocal plus, a NIDOF, and a full range of vision that they are really getting a beautiful clinical result, as you will see. Some very quick images on tests, and maybe the next is also on bench through focus, where we can see our superiority of our lenses 40 and 70 as compared with a trifocal. I think one of the best trifocal. So this is very quickly the summary. I'm not even reading this because I want you to start as soon as possible. But we have a completely different concept of lens that is tackling two issues. Better periphery that can be important for normal life, better all-range vision without photic phenomena. This is the concept, this is the idea, and I'm super happy that you are going to talk now about what you get in your patient. So thank you again, and then we can move to the first presentation from Professor Secundo. So Walter, please.
Yes, thank you, Luis. Well, basically, the idea was this small, I called it pilot study, was to see, how it will perform in patients who have perfect vision, which are the patients for refractive lens exchange. And in my hospital, in my setting, this is a fairly large part of the patients I operate them. And so if you can go to the next slide, Luis. Yes. The idea was to compare it with a very well-established lens, and we've been using the Acrysol Vivity intraocular lens for the last, well, at least 6 years, and I was also part of a multi-center study. It actually works very well for us, and I've done over 1,500 refractive lens exchanges with a blended vision concept, similar to Press Beyond, where we correct one eye for distance, which will give you a distance intermediate vision, and the fellow eye would be corrected slightly for myopia of about minus 0.75 diopters, delivering intermediate vision and near vision. So this is how we work. But as you know, the Acrysol Vivity works as entirely different optical path and a different concept. So the idea was there just to see, how those two different concepts, as was just shown by Pablo, and the one, from Alcon compare in refractive patients. So the next slide, please. So what we did, we decided just to compare it with a Vivity lens, and just for you to know, we already did a small study where we checked the blended vision concept and presented in 2022 on 30 patients, basically actually showing very good results with Vivity. And obviously the question was here, is ArtIOL going to perform at least as good, if perhaps better, than the lens that everybody knows? Next slide, please. So we can jump over, because Pablo already explained the concept. And next slide. Okay, I think it's important, although Pablo mentioned it, because the idea was to get a full range of vision. And we always talk about binocular vision, because if you do like mini monovision, blended vision, we're talking about binocular vision. So we're going not to talk about single eyes, but a binocular vision. And this is a study that was published by Dr. Marini Jerez 2 years ago. But these, again, were cataract patients. And obviously, cataract patients are always happy because they see better, because they get rid of the cataract. Whereas refractive lens exchange, the patients are more demanding and they really expect freedom of glasses. Next slide, please. So, these are the two different lenses. Everything been explained. The patients included had to have a best corrected visual acuity of 0.8, which is 20/25 at least, or better. The vast majority of them had 1.0, which is 20/20 or better, with some even 1.25. No other obviously ocular pathology. We had to choose patients with astigmatism less than 1 diopter because the ArtIOL as available to us did not have the toric component. So we had to correct the astigmatism if it was any astigmatism by incision. And, we check every single patient before we apply the blended vision a blended vision concept. We do, which we call a Prisbeyond test. The test has been developed by Dan Reinstein and his group, as we use for laser refractive surgery. And we follow up for at least 3 months. And we had 20 eyes in each group. Next slide, please. Okay, so 10 patients were implanted with the Acris of Vivity. The distant eye was, ended up basically being more or less almost zero, minus 0.12 diopters. And we call it a reading eye. It does not always have to be a non-dominant eye. Sometimes there's enough patients who have a cross fixation. The reading eye was roughly around minus 1 diopter. For the ArtIOL group, the distant eye received the ArtIOL 40, which has a lower spherical aberration as the 70, and we ended up being just slightly a little bit more myopic compared to Acris, around minus 0.25, again with the reading eye around minus 0.56, but the reading eye would have the ArtIOL 70, which by itself has a more depth of focus as compared to the ArtIOL 40. When you look at the implanted power, there's no big differences. Okay, it's 22 diopters in Vivity, it's 23.5 in ArtIOL, all identical age, typical age for refractive lens exchange. And what's important is I never, ever do refractive lens exchange for myopic patients, full stop. So what you see here are hyperopic patients, usually low hyperops, a few emetrops, but in the majority we're talking about refractive lens exchange in hyperopic patients with low astigmatism. Next slide, please. And here are the results. Okay, so first let's talk about the post-operative refractive and binocular uncorrected visual acuity, because this is what these patients or clients are aiming for. And this is why we chose a 2020 uncorrected and a 2025 uncorrected. Why 2020? Well, this is sort of the best target, more or less possible, and 2025 gives you a good everyday's vision, even if you cannot reach 2020. So the 2020 ArtIOLs was just slightly better at all distances, far, interim distance and near, whereas for 2025 was more or less the same. Still, it was not statistically significant. Next slide, please. When we look at the entire range of corrected versus uncorrected vision, again, on your left-hand side, you see the ArtIOL best corrected compared to Vivity best corrected, and the results are quite similar, although, again, in 2020 group, the ArtIOL did perform better. In terms of uncorrected visual acuity, and again, this is what we really were aiming for, both lenses performed quite good. And the next slide will show you the only important difference between the two lenses, and was the uncorrected near visual acuity. Although, as you can see, in terms of spherical equivalent, Vivity in the reading eye was always set at around -1, where you would expect a better near vision. Still, ArtIOL 70, which was chosen for the near eye, performed better. And this is where I put this little arrow. So it was more reminiscent of the trifocal lens in terms of a defocus. Okay. Next slide, please. And it was statistically significant. This was the only statistically significant point. And, as usual, we also ask the patients about their satisfaction. And there's a questionnaire, the CATQuest questionnaire, which is used in a variety of studies. Important tasks like reading newspaper, face recognition, and you see more or less the same, with better results for face recognition for the ArtIOL. But in general, both groups were happy with the results achieved. So next slide, please. So what is the conclusion? Again, it's a pilot study. It's not a large-scale study. It's a pilot study. But at least we can say that both intraocular lenses, when applying the concept of blended vision in hyperopic refractive lens exchange, really achieved a high satisfaction rate. Both intraocular lenses provide a good to excellent binocular unaided vision at all distances when used as a blended vision. And what we could see that the Art 40 in the dominant eye, Art 70 in the reading eye combination achieved a better uncorrected near visual acuity, which was 1.25 versus 0.8 decimal, and which was the only significance. So I think when you look at a new lens entering the market, I think it's worth to compare it to the lens that's been sold for over 1 million times, and say, okay, it's at least as good and perhaps even better. And obviously for the other things, like Pablo mentioned, these photopsias, whatever, we did not have any problems in any of the groups, but the groups were too small. I mean, when you look for these photopsias, obviously it's not enough to have 20 patients. You've got to have whatever, I don't know, 1,000 patients, then we could make statistics. Thank you very much.
Very much, Walter, and this is great. We agree it's a small group, but it's very nice to. We are David against Goliath, right? So it's nice to see that our lens is performing better than the others. So thank you very much. I think we have probably many questions, but we will have all at the end. So let's move to Dr. Rechichi for the next presentation. So Miguel, the floor is yours.
Thank you. You can hear me well, and you can see also my screen.
Yes.
Perfect. So honestly, the first time that I look at this beautiful lens was in an ECOS conference in Florence, in which you, Pablo, presented this kind of IOL. And honestly, as soon as they was available in Italy, I was really struggling to try this experience, because the concept at the base is very, very strong. And I was very happy to start my little experience, but I will show you my honest cases. And I don't have still too much number to make statistic, but I want to show you the real life and the quality of this lens. So my experience with ArtIOLs actually is a small experience, 10 bilateral implants for the R25 and 10 bilateral implants for the ArtIOLs 40. And what I did is to analyze this patient, and I excluded the patient with more than 2 diopter of astigmatism because actually I do not have the toric version of this lens, but all the astigmatism up to 2 diopter was treated with a automated femtosecond laser incision, the arcuate incision. And then I focused on postoperative refraction, uncorrected and best corrected, and especially at aberration profile, that I think that actually is the real show of quality of vision. I want to show this patient in which I implanted the ArtIOL 40 with a planned micro monovision left, and I left minus 0.5 in the right eye and pointed at the ametropia in the left eye. And I want to show how to implant this lens. The lens is very simple to implant. It's important to hydrate the lens because In this way, it will slide very well in the cartridge. This is the solution that Voptica sent to you. Is the Medicell injector, and in this way, it's just so many important to put the optic, the rear optic under the plate, and in this way, after wetting the IOL, I will show you in advance. Okay, this is the injector. My honestly, I prefer to implant this lens in 2.4 wound. So in this way, I can see very well the lens. In this way, okay, I'm enlarging to 2.4 in this way, and then you release the lens. The lens is very soft, so in this way you can control very well, and also the optic is very soft, so you can easily reposition, and the lens, the quality of the lens is very beautiful. Is so smooth also to deliver, and is very safe. And I want to show you the result about aberrometry. So as you can see now, okay, as you can see, the quality of vision is very good. If you look at the Strel ratio, is like the quality of vision of a 20 years old patient, and also the profile of aberration is all in the green. So this is a sign of a quality of the lens. This is the left eye. In the left eye, there was some initial PCO, but I prefer just to do Yaglaser after 1 month. But what really impressed to me is the focus curve. As you can see, I pointed at minus 0.5 in the right eye and the metropia in the left eye. And if you do micro monovision with this lens, you will have a dramatically improve in the range of amplitude and without really compromising the quality of vision. And actually, my choice now when I implant RT40 IOL is to look at the micro monovision. In this way, I have an amplitude that is comparable to a trifocal lens, but without the loss of quality, as a lot of trifocal IOL shows. This is the aberration profile. As you can see, is very smooth, with a very smooth transition. And to me, the most important thing, if you look at the green, you have an area of homogeneity that is quite the same from the center to the periphery. And this is consistent with what Pablo said, that the quality of the lens is not still in the center, that is quite obvious for all the IOLs, but the quality of the lens is especially in the middle periphery. And this is the reason why the patient can see very well also in driving in the night. And if you can see the Strel test, for example, for this patient, is quite comparable to a monofocal IOL, but with a range of amplitude of a trifocal, especially if you do micro monovision. So to me, the best thing of this lens is really the quality of vision. I will show you another cases. In these cases, I implanted the lens with a conventional Monarch, and sorry for the sound. And okay. 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 And as you can see, you can also implant easily with the Monarch if you're not confident with a Medicel injector. But the lens is very, very easy also to deliver with a Monarch system. But what the patient tell about this IOL? I do also a quality of vision questionnaire for this patient, and the patient was very satisfied, especially for the halos, the glare, and the starbust. That they do not complain in most of 90% of the population of my little study. And this is so important because when you promise quality of vision and also depth of focus, sometimes the patient are very happy in the day, but in the night for conventional lenses, sometimes is a disaster. But in this patient, they have a quality of vision that is really comparable to monofocal IOLs. And what about the spectral independence? So most of these patients, especially with the micro monovision, they can see very well also and near in more than 50% of the cases. And we are talking about a need-off lens, a need-off that provides a good intermediate view. But in these cases, using the micro monovision, also in more than 50% of the patient, they was very satisfied with the near, especially in also in mesopic condition. So honestly, this is the state of the art for overall quality of vision. And what about also the precise of calculation? Most all this patient was within 0.5 diopter for emmetropia. So also the calculation is very, very precise. So in conclusion, my early experience with RTL 40 is that they provide an excellent visual acuity at all distance and a high spectacle independence and really minimizing the photic phenomena. I did not have one patient with negative dysphotopsia, and as Walter showed, especially in hyperopic patient with the EDOF lens, the phenomenon of dysphotopsia is quite frequent. I do not have one patient in the hyperopic group that had one of these problems. And what it is important also for me, but especially for the patient, that we have a contrast sensitivity that is quite comparable to the best monofocal IOL. And the quality of vision referred by the patient is outstanding. Actually, my only issue is that I do not have the toric version, but Pablo said to me that it will be soon available. So actually, I'm managing my patient with a arcuate incision by femtosecond laser, but I think the toric version will be soon available. So I would like to thank you for inviting me in this beautiful webinar. And I'm sure that RTOLs has a great future. Thank you.
Well, thank you very much, Miguel. This is really fantastic results. I'm really very happy, and it's very complimentary because well, you decide to use only 4. I think well, I hope you can also jump to the 70s at some point, and you will see how nice. So then we move to the next presentation is Dr. Daya Serat. Thank you very much, and the floor is yours.
Well, thank you very much for inviting me to speak. Can you see my presentation there? You can, yes?
Yes.
Great. Well, thank you very much for involving me in this presentation, and it's nice to see the variety of outcomes there that from different using different combinations of the ArtIOL and also comparison with the Vivity. So I'm going to show you, talk a little bit about my own experience in the use of these lenses. Is this in presentation mode?
No, it's not. Yeah.
No.
It's it should be.
Exactly.
Oh, there we go. Okay. Can you see it now? Yeah.
Perfect. Perfect.
Perfect. Yeah. All right. Let's get rid of this thing here. Okay. So as you've already heard, why is this not moving? As you already heard, this is the way in which the lens is designed is very clever, being an inverted meniscus implant, and in so doing, it can also it improves peripheral vision, but also by increasing negative spherical aberration, there's a provision of increased range of focus. Now, just a quick word about terminology. It's a bugbear of ours at ACOS. Where people keep talking about EDOF, and I think that's the most confusing term I've ever heard, because they mix up terminology with the concept with mechanisms of action, and I think you need to differentiate the two. Apart from anything else, EDOF, the standard to meet EDOF is only 50%. 50% of patients require intermediate vision to meet the criteria of EDOF. And my question is, what do you do with the other 50%? I can't really say something's reliable at the same rate as tossing a coin. So what we at ACOS did was look at the nomenclature, and we divided it up into different components. But our standard is 80% must have distance intermediate corrected visual acuity of 0.2 rather than 50%. And I think that's a much better bar to follow. So lens performance really is a range of focus, which we've been talking about, an increased range of focus. And there's a mechanism of action which Pablo has elegantly talked about with regards to inverted meniscus and the increased spherical aberration. And then there's the issue of dysphotopsis, which comes about from the mechanism of action. And very nice that we have a lens that actually does not cause any dysphotopsis at all. So basically, we've got these categories of lenses. A monofocal, somewhere in between increased range of focus and monofocal will be a monofocal plus. And then you've got the full range of focus. So our experience, well, we commenced by doing the 40-70 as recommended by Pablo et al. and his co-workers. And we did 8 patients bilaterally. The mean age was 69. These are all patients with cataracts, equivalent between males and females. And later on, we thought, well, if you're getting more range of focus with the 70, why don't we just try 70-70? And we did 5 patients bilaterally, and we have a few more lined up now. But I wanted to test the water to see how they did before going out and go all guns blazing. You can see this was a slightly older age group. And so talking about implantation, the lenses can be quite sticky, and there are a few little tricks that are useful to articulate. This is the lens we put in. I like to have the lens unfold inside the bag. So I put the haptics in underneath the ledge there of the Medicel cartridge. But on top, I will use HPMC quite liberally to try and avoid sticking. I push the lens forward, but I pull back to make sure I don't grab the distal haptic, and I don't waste any time in injecting the lens into the eye, because the more time you take, the more it wants to stick to the optic. The great thing about the sticky lens is it sticks to the capsule, and we haven't had any patients yet who have had to have a YAG capsulotomy. They're all have nice clear capsules with an adherent IOL, which is posteriorly vaulted onto the capsule. So that's another thing that's not been discussed, but it's been our observation. I don't know if Volta or Miguel have found the same thing. So looking at these patients, because we've got different lenses in different eyes, we have to look at each one independently. So the dominant eye had the ART 40, and the non-dominant eye, the ART 70. And looking at the refractive outcomes, then we aim for micro monovision as well. And you'll see the non-dominant eye outcomes were about minus 0.8 mean compared to minus 0.3 mean in the dominant eye. Cylinder was low in all. And those that had astigmatism, we did limbo relaxing incisions with a femtosecond laser. So here we're looking at this is the attempted versus achieved, and in the 2 different groups, and you'll see that they're exactly the same in terms of outcomes, absolutely identical. I had to look at this data twice to figure it out. But in terms of attempted versus achieved, remember we were attempting myopia in the ART 70 group and emetropia in the ART 40 group. Looking at the dominant eye and the non-dominant eye, you can see the visual outcome, the refractive outcomes were within a diopter there. Uncorrected distance visual acuity. Now this is binocular. Patients, they neuroadapt with both eyes open. They don't neuroadapt with one eye at a time. So we always find that the binocular vision is better. But what's really impressive is how much better they are with the ART IOL. And you can see that right here. There's 88% are saying 6.6. binocularly. Whereas if you look at the monocularly, it's only 63% with ART 40 and 50% with a myopic with the ART 70. But combined, they seem to do a lot better, and quite considerably too. And same with the 60. Now we don't measure at 67 centimeters, we measure at 60. A long time ago when we were using the crystal lens, accommodative implant, I went around with a tape measure to see what the distances were. And the laptop is about 60, a dashboard in the car is 80. So that's what we used, and we've been using that ever since with our software as well. And these are the outcomes here. So if you're looking at 0.2 logMAR, which is the same as 2032, well, 100% get it. And they do monocularly with the ART 40, and they certainly do with the ART 70. So again, we've more than met the EDOF standard. We've actually more than met the ACOS standard for increased range of focus. This 80 centimeters does even better than 60. And 40 centimeters, this was quite a surprise. So we had patients who were fairly independent of glasses. They'd only have to use a pair of glasses in very dim light. And 80% were 20/25, 88% were 20/25 or better. And meeting the 0.2 logMAR scale, 100% got that level at 20/30. And you can see that this is quite impressive here. This is 20/30, 100% got that in the ArtIOL group. For some reason, the ART 70 didn't do as well, but these were 1 month data. And I have seen patients since, and they seem to do better. I think they take longer to neuroadapt with the ART 70. So this is the summary of those results. And you can see that ART 40 seemed to do very well at all distances. The ART 70 at distance, well, they were myopic, so they didn't do as well. Did very well intermediate. And for some reason, at 40 centimeters, they didn't do so well. But binocularly, they did well at all distances. Looking at defocus, this is an example of a patient. This is the dominant eye, the non-dominant eye, and the cumulative binocular defocus. And this is the 0.2 logMAR level. Looking at contrast, and this is the pre-op and post-op. And this is the ART 40 and the ART 70. So the monocular data did not look good, and the non-dominant eye did not perform as well as the dominant. Well, that's to be expected because of the myopic shift by intention, and also the implant. But we thought we'd just go ahead and use the ART 70 in both eyes. I know patients like to be able to read, so here we want to push them. So we did 5 patients bilaterally, and we aim for +0.25 to +0.5 in the dominant eye and plano in the non-dominant eye, with the understanding that the lens sort of shifts towards myopia anyway. And these are outcomes. We had one outlier here, which was a bit of a refractive surprise. The lens didn't sit as posteriorly as we'd expected. And this is the same patient here in both eyes. She did the same thing. So this kind of skews our data, but that's okay. I've included them all here. And these are the outcomes. Preoperatively, they were hyperopic. Postoperatively, minus 0.44 diopters. This is the overall group. Uncorrected distance visual acuity, this is the dominant eye and the non-dominant eye. And you'll see that the non-dominant eye was a bit myopic, and you can see that the distance vision was not as good as the dominant eye. But binocularly, binocularly here, you can see the cumulative 80%, we're seeing 6.6 or better. So it's quite interesting how monocularly they don't seem to do so well, but the 2 eyes together do very, very well. And I think a lot of it's to do with neuroadaptation, which is what we naturally do when both eyes open. At 60 centimeters, they again, 100% got the increased range of focus standard from ACOS, and they certainly did binocularly. Again, 80 centimeters, extremely good outcomes, 100% seeing 6.6. And at 40 centimeters, this is what we really want to know about on patients. This is the dominant eye, the non-dominant eye. So you can see the myopic shift certainly helps. This is the logMAR 0.2 or 20/30. And this is a monocular uncorrected near visual acuity in the overall group. And then this is binocularly, looking at the binocularly, 100% get 6.9 or better, 80% 6/7.5, and 60% 6.6. This is the defocus curve on the 70/70, the dominant eye, the non-dominant eye with the shift, the myopic shift, and cumulative binocular contrast sensitivity, again, pre-op and post-op. it's not quite clear why they seem to do slightly worse post-op with 3 to 6 cycles. But I think a lot of that goes also back to neuroadaptation. It's worth looking at those patients again in a few months' time. So this is the summary again. At distance, they didn't seem to do so well, which is consistent with what we found with the other with the 40-70. Intermediate did very well, and near they did extremely well binocularly. This is one patient that had both lenses were 0.7 millimeters more anterior than predicted, both eyes, and that's why she was a bit myopic after surgery. So in conclusion, the ARTS 40-70 combination seemed to do better at 6 weeks than the ART 70-70. I think the ART 70-70 needs a bit more time for adaptation, and again, we need to check that out in time to come. Certainly, what we see in terms of results and what the patients tell us, I can tell you that the group, the ART 70-70 group, are way more happier than the ART 40-70. We're doing patient-reported outcome measures independently. It'll be interesting to see what the combination does with these patients and what they report at the 3-month mark when they're asked to review. So binocularly, they do very well. And there's this summation of peripheral good focus and the range of focus, and a few unanswered questions. Maybe Pablo can enlighten us a little bit. But certainly there have been no dysphotopsias, and all patients except one, the one that had a myopic surprise, was spectacle-free. So thank you for your attention and for including me in this seminar.
Well, thank you very much, Sheraz, for these nice results also. I'm really so happy to see, and also very complimentary. So then we completed, I think we are very nicely on time. So we have some time now for questions from the audience. Also, I think we can include some cross questions from you, because you have actually different experience. So actually, I would like to spend a few minutes, if you wish, having some of your question between yourself, because maybe you want to know something else from what the other speakers are presenting. Who want to start with any cross question?
Yeah, I can start. So to Miguel, you took a very cautious approach with using the ART 25. We didn't even bother with that. But was that a cautious approach, or what was your intention there?
No, was a cautious approach, as all the new IOLs that I just to implant. No, as you know, I am a private practice, so before switching to a new technology, I always start to a cautious approach, and then once I get confidence, I go over. And honestly, what I was really astonishing is the quality with the 40, especially if you implant with a micromonovision. The patients are so quite happy, and honestly, most of these patients just wear +1 for very little things, for J1, but they're so happy. And to me, honestly, the quality of vision is the most important things. And I think actually micromonovision with the 40 is one of the best compromise in terms of quality of vision overall. Honestly, this is the reason why. I do not have still experience with the 70, but looking also at your data, I'm so curious to combine, because your approach is the next step. And I think in a motivated patient is the best choices, especially for the patient who want to be really completely independent from glasses. But honestly, most of my patients do not care if they just take +1 just in some few situations, but the quality of vision of night, honestly, is the best IOL that I have in my pocket for night vision.
Great. So Walter, Walter, the 40-70 experience was kind of similar, actually. Did you go straight to 40-70, or did you?
Oh yeah, sure. We're refractive boys. We don't fiddle around with monofocal lenses. But I had a case sort of similar to yours, but it was incidentally where I had to implant 70-70 in both eyes. Actually, it was my mistake. I was going to implant the at 40, and because the 40 and the 70 had the same dioptric power, I made a mistake and implanted the 70. And once the patient got out of the OR, I realized, oh gosh, I implanted the wrong lens. So I went out, talked to him. His son told me, go and exchange, because if you want, I can exchange it immediately. You can just go in and I'll do it. But why don't we wait? So fortunately, this guy decided to wait. I said, I can do it for you tomorrow, I can do it after tomorrow, but let's do another eye. We don't do it simultaneously. Usually there's 3 days between the two surgeries. So I only have one patient with the 270s. Again, preoperative visual acuity 6.6, best corrected. I don't remember, it was like +2, +2.5. And with both 70s, now happy. Uncorrected distal visual acuity 6.6, which is 1.0. Uncorrected near visual acuity 0.63, which is 20/30, but not better. And this is why I'm sort of trying to figure out, but perhaps we even don't require the 70. Perhaps it's enough, because the monovision is probably one of the biggest surplus factors for good near vision. And perhaps one can even get away with 240s with a decent monovision of, let's say, 0.75 diopters, but definitely not more than 1. This was my experience actually with the other lens, the Vivity I compared it with, because initially I basically wanted to carry out the same idea as Dan's idea with Press Beyond, where we could go up to 1.5 diopters difference if the patient accepted. And this was another study where I only showed one slide. And yes, there was a high rate of independence from glasses when the difference was larger, which was like, I think, minus 1.25, but the complaints were higher. And this is why, at least for the Vivity, I never crossed now more than 0.75 diopters, even though lots of patients, would accept 1 diopter, 1.5 diopters of difference. So in some ways, I basically transplanted the same concept on the ArtIOL in order to compare those. And for me, I think it's a very competitive lens. And again, you guys, once you will have the toric version, then obviously it will be a huge influx of new surgeons would like to try it, because not everyone has a femtosecond laser. And yes, of course, I could do A-key, I could do LRIs, but this is like going back to the 90s,
By the way, I just remind the audience that you all can have any questions to the speaker. So I don't know, Luis Consuelo, if there is already any question from the audience. You can just tell.
Yes, we can publish for the time being. There's no interaction in the audience, but please feel free to go ahead and ask the surgeons about any doubt you might have about the lens. Yeah. Or the presentation.
In the meantime, I think I just going back to Sheraz last part, and we always try to be like Miguel, super cautious, right? So we were starting very, very slowly and going to 70/70, I was always a little bit nervous, thinking if what can happen in patients that they really want to have very good distant vision. And when you saw is really very promising also, right? Because for many patients, I think this can be a very good solution, because of course there is nothing free here, right? So with 70/70, you can have a little bit of distance reduction, not so crispy, not so super good, but many patients are happy with that, and then they are very spectacle independent. And one point that you made that it's really interesting, and I think we don't know exactly, we need probably to do more studies, is what is the role of binocular summation here, right? That is clearly helping, but we don't know how much.
No, but this is what Sheraz showed. Monocular vision was not that good, but once we were looking with 2 eyes, it just jumped up. And this is summation. It's exactly what went through my mind.
Yeah, exactly.
It's all about the patient.
Luis? Any question for the audience? We want the audience to participate.
Not yet.
I think that the key is that the patient satisfaction is extremely high. So when I look at the data, so we do a lot of trifocal lenses, and the monocular data and binocular data is good. I mean, that's where we're looking for full range of focus, but they do get some dysphotopsias, and sometimes you get negative dysphotopsia as well. And they will complain about those things. But the level of satisfaction in these patients, where I got the impression, again, we need to see the PROMS data, but I got the impression that they're much more ecstatic about their vision after the ArtIOL than perhaps the other ones. And I think a lot of it's to do with the quality of vision that they're getting. With there's no dysphotopsias, and they got great peripheral vision, which you probably underestimate. I think if they've got good 60-degree range of vision at a minimum, that they can function extremely well. And we don't know what the other lenses are doing in terms of peripheral vision. We know they get great central vision, but we're not really sure about the periphery.
I think that these photosopsia are the most shadowed problem for the big company, no? Because each of us experiment negative dysphotopsia with the IOLs, especially to me in a hyperopic patient. And this is the reason why I'm so cautious, but now I'm very, very happy for this lens, because I'm sure that 99% of patients will do not have dysphotopsia. And when you implant a needle for a trifocal lens and the patient pay a lot for this, the patient don't want to have any problem. So I'm sure that with this lens, I'm confident that for sure it will not have this kind of problem. It is really important, because also when you market a lens, that is premium, you have also to be sure that your patient will not have any other complaints respect to the vision before the cataract. And for this reason, this lens is really, really useful.
I've got two questions to Paolo. Paolo, two questions. Number one, if you claim that the peripheral vision is better than with a standard lens, what size of a capsular axis should we aim for? Because if we're going to create a small capsular axis, probably too much of the optic is gone. So from where on is sort of the part of the optic that at least needs to be still open? Is it a classical 5mm, 5.5 millimeter capsular axis for a 6mm lens, or can one go even smaller? This is question number one. And question number two is, does it make much sense also to look at the spherical aberration of the cornea by adjusting, at least partially adjusting the aberration of the lens, and perhaps, particularly when treating post-laser refractive patients, these are the patients I'm sure Sheraz and I deal a lot with.
Yeah.
Those two questions. Capsular
They're
axis.
very good, very great question, both of them. The benefit that we have for the periphery, it comes with a smaller pupil also. So I think this is not going to be an issue. You can do whatever you want. Not big different if you do a smaller size. And the other, this was my idea, right? Initially, we start with 4 model of lenses and because I have in mind that we want to customize everything, and including spherical aberration of the cornea. So if you want to do it, that's for sure an advantage. You can even refine what you are getting. The reality was that in the early clinical experience, the results were so good even without considering corneal spherical aberration that we stopped telling, because many doctors, if you are asking for more and more evaluation, it can be an issue. We wanted also at the beginning to use our adaptive optic simulator, because we know that not everybody responds the same to the same amount of spherical aberration. So the initial perfect approach will be measuring corneal aberration, doing the test with the neural responses with the visual simulator. But the reality is that you are going to you customize, you can increase even a little bit more what you get, right? But well, there is always a balance, right?
There's a question here from somebody about this, about measuring high order aberration before implanting an art lens. Does one measure? I measure it on every patient, and the one I worry about is coma more than anything else. And what is this cutoff point? I mean, I don't have a cutoff point. The one that's really interesting, which I always smile about, is the angle kappa effect on the quality of vision. I mean, this has been investigated. I always thought it was a lot of nonsense because the lens is so close to the nodal point, and this lens in particular vaults quite posteriorly, so it really is at the nodal point, and that has a zero impact in terms of angle kappa. It is just far too close. I think what we're doing is extrapolating from laser refractive surgery on the cornea to lens surgery, and that's the wrong thing to be doing. So I don't think angle kappa makes any difference. And Ahmed Asif in Egypt, who told me that it would make a difference, until he studied it, realized there's absolutely no relevance whatsoever. But looking at high order aberrations at 4 millimeters, I do that on every on the cornea on every patient. And if I have coma, I start worrying about those patients. In fact, I sometimes use that coma to give them multifocality by putting in a monofocal lens.
This is very good, and I really glad you said that. One of the advantages of our design that not too many people is aware is that actually the nodal point is back, is closer to the real than in the real eye, right? Without, and then this is, of course, no importance on this angle, but some potential benefits because we are moving this a little bit backward, right? But Miguel have also a lot of aberration measurement, right? So maybe you can add something to the question.
Oh, yes. What I saw also that in patients with a non-normal aberrated eye, they still have a very good visual acuity after the implantation. So this is the proof of the quality and of the optic of the IOLs. I have also a patient that I will show. I cannot show you because I do not have the 2 months data with a initial keratoconus, so with a spherical aberration that is also unusual, and now is very happy, more than before the lens surgery. And I treat a lot of patients with a keratoconus. In this case, I implanted at 25, honestly, not 40. But if you look at the aberration before and after, it has obviously a refractive lens exchange is what's really a cataract, but the quality of vision before and after is really impressive. So also in a aberrated eye, the quality of the lens overwhelms this kind of aberration. So honestly, the 25 is the lens that I will put in a aberrated eye, not the 40.
I think
very good. Now
we has raised their hand. I think somebody's raised their hand. It looks like Eric Mittens.
Yes, we have a couple of questions in the chat.
There is a few more questions. One is actually for you, Sheraz. That how do you select your patient for this IOL, since most of our patients want to be free of glasses for reading? Mm-hmm. And what do you tell them? What the difference with trifocals?
Well, I think the thing is the question is, are they? Why would I put this lens in instead of a trifocal? That often, I mean, I'll be honest with you, these patients may have the ones in this series may have had mild macular degeneration. I'm not going to put a trifocal in that patient. Some of them have glaucoma without field cuts, but a little reduced sensitivity. Again, I'm not going to put a trifocal lens in those patients. So those are some of the ones included in the series. If they want a sure thing, if they want absolute definite near vision, then I can only do that with my hand on my heart by giving them a trifocal lens. And the majority of lenses that I put in are trifocal lenses, and they do very, very well. I've been doing them since 2011, and I put in about 10,000 of them. But I'm always interested in other alternatives for patients who absolutely. I had somebody today who drives a lorry. And I'm not sure I want to put a trifocal in somebody who's a lorry driver and wait for him to neuroadapt over a period of 3 months. In his case, for me, it's easier. It's easier to use one of these lenses in their eyes, but what does he need? He needs to be able to see the road, and he needs to be able to see the dashboard. And if he gets extra near vision, well, that's great too. That's a bonus. So we usually hedge and tell them they might not get it. And then, in the sense I'm underselling it afterwards. They go, hey, I don't need any glasses. You said I would. Well, that's a bonus. And they're happy patients. So it's what you say to patients that really matters, and addressing what their concerns are. If they absolutely want to have near vision, then I can't say, put my hand on my heart, although the results show otherwise, hand on my heart said, you'll definitely get it. You'll definitely be out of glasses. I'd rather tell them the worst. So if they want to be out of glasses, we put reading glasses, then we'll give them trifocal lenses. That's basically how I play it.
Yeah, this is something important. By the way, we already passed the hour, and we don't want to take much of your time. So maybe we if you are okay, we can be here like another 5 minutes or so. Yes, and there is you mentioned something, Sheraz, that is very important. Is that our lens love the retina. Some people say that, right? So any potential issue with the retina, this is the best lens that's possible, right? So that's another option. There is another question that I'm going to take very quickly. They ask about what is the problem, the effect of decentration with this lens, and this is a very good question also, because especially with the 70. It has a lot of spherical aberration. I don't think there is any other lens with so much spherical aberration. And when spherical aberration is decentered, you can induce coma. So, and this cannot be testing. And there is no real, and we don't have any kind of bad results clinically for the standard decentration in normal surgery. If for any reason you have a super decentered lens that is not happening today, you may notice something, but not that much. So maybe we can have to be on time, if you wish. You have a final run, Walter, Miguel, and Sheraz, and because I think that's probably a good idea. So you want to do it, Walter?
Well, basically, I think it's the most. Actually, I like Sheraz. I gave up on trifocal several years ago. Now it's less than 1% of my patients. And again, I do about 500 purely refractive lens exchanges annually. They're all based on mini monovision using extended depth of focus. And I mean, we're talking about non-refractive. And I showed you one option, from a large company, you all know, and now it's a real, a good competitor. And what I really wait for is a toric version. I do need the toric version because I don't do femto-assisted cataract. I do manual cataract, so I do need the toric version. So now you know what's your homework.
Yeah. Well, I have to say that the toric version is designed long time ago. We have samples, and we are in the process of the registration. We get this MDR in the middle, right? So that's the problem, and we are very small, as you know. So everything for us is like super difficult. But well, this is life. So Miguel.
So okay, I do not implant trifocals since years, honestly, because I'm so cautious. But the quality of vision with the Forte and is so high that honestly could be implanted in all the patients, especially the patients who are very critical. So it saved me in the day after, because also these patients are very, very happy. Another ethic question you mentioned, I think. The 25 especially should be the lens for patients with the macular diseases, because they have more contrast sensitivity in the periphery, no? And you know that also there is some IOL marketed for AMD that have some degree of contrast sensitivity in the periphery, but this should be the IOL for patients also with the early AMD. And if you have a patient with the early AMD, you want to be less independent from spectacle, the 40 is the right choice, honestly. Basing on my data on aberrometry and contrast sensitivity. So please, you should market also these LEDs for early IMD because it has
this is also
the
a very
characteristics.
good point. And well, I think I can share that actually we have another lens, another design that is actually intended for AMD even more. We are pushing even more for AMD patient. But of course, any of our lenses, 25, 40, even 70, can be good for those patients. But wait for the new one. The new one is going to be a super lens.
We're there.
So, Sheraz, please.
Well, I still do a lot of trifocal lenses, unlike the other two. I think I think the issues of dysphotopsis in those patients is kind of overrated. But like many colleagues, we're always in search of newer things and newer implants. Personally, dysphotopsis, it means I spend more chair time talking to patients about what they expect, and they're fine. I have not yet, knock wood, explanted a single trifocal lens in a patient. I've done a lot of them, but I'm not crazy. I'll select those patients extremely well. So if they've got dry eye, I might put this lens in instead of a trifocal lens in because they're unforgiving in that regard. But then, there are many different lenses out there. I've home in on just a few that I have a lot of experience with, and that keeps me on the straight and narrow most of the time.
Okay, well, thank you very much. I think we are stopping here, and I really would like to thank all of you for being here. A special thanks for the Boptica team that I know they had been preparing this event for a long time and doing very carefully. And thank you very much, Walter, Sheraz, and Miguel for being here and sharing your own experience with the lens. And thank you all the attendants. And if you have any other question or anything, please contact the Boptica team or your local representative for more information. Thank you to all.
And I would like to add the last things that for the new user of Optica, that Optica have a very great team, best team, that answer you in seconds. So this is very important for your first implants.
I should say that you are completely right, and the team is better than the lens, and the lens is very good.
Okay.
Thank you.
Okay.
Thank you.